I'm Bob Becker, Director of the Strom Thurmond Institute, and it's my pleasure to welcome you to tonight's program. It's nice to see such a great turnout on a fall Saturday evening in this lovely facility, so thank you for coming. I think you're in for a treat. This is the William Hunter Endowed Lecture, and it's a very special evening for us. Bill was the mainstay of the Calhoun lecture series. I used to tell the story that the way it got started is Bill used to keep coming by the Institute and phoning and saying, I have an idea for a speaker. And then we'd start pulling the speaker together, and he kept doing this so often. I said, Bill, why don't you take a desk here, move in, become director of the Calhoun lecture series, and we'll turn it into something that'll make Clemson very proud. And Bill stayed with it, and this lecture was a lecture that he helped decide who would speak. He and Harold Morris, he and Dr. Morris sat down and said, he really wanted to hear Paul Farmer. So we know he's listening, and so it's a pleasure this evening to welcome you to the Endowed Lecture. The endowment was made possible by generous gifts from the friends of Dr. Hunter. And that program, the committee to raise the endowment, was headed by Dr. Tom Tootin, and Tom is here, so please, a round of thanks for Dr. Tootin and all the donors for the Hunter Lecture. If you hadn't noticed already, the bookstore has a table set up, and they are selling books, as bookstores usually do. So if you'd like a book, Dr. Farmer is very gracious with his time, and afterward he'll be sitting down and signing the books, and you'll have a chance to meet this distinguished individual. Following the presentation this evening, we have a panel format set up, and the panelists for this evening's program are Dr. Rosemary McDonald of the Redfern Medical Center here at Clemson University. Dr. McDonald, thank you. And Professor Catherine Weisensee, and she's with the Department of Sociology, brand new to Clemson from the University of Tennessee. So please welcome our panelists, and they'll reintroduce themselves when they come up on stage during the questioning. So thank you very much. We're also very pleased with the partnership that we have with the Hunter Endowment and the Hunter Lecture with the ANMed Medical Center and ANMed Health and the foundation. And they gave a generous donation to help pull this program together this evening, and we'd like to offer a special thanks to them. And representing ANMed is Mr. Garrick Chedester. And Garrick, would you come on down, please? We have a little thank you. Garrick, on behalf of your support and ANMED's support for the William H. Hunter Endowed Lecture, we want to thank you very much and give you a small token of our appreciation for your continued support. Thank you. Now, as I mentioned, the program today was actually started with Dr. Hunter and Dr. Morris, Dr. Harold Morris, talking about who could be this a speaker at the Hunter Lecture. And to the very end, they were talking about this, and it sparked him up. It sparked Bill up. And so we were very pleased when we were able to pull this one off and bring in Dr. Farmer to fulfill this last discussion that we all had with Bill Hunter. And to introduce tonight's speaker, it's my pleasure to welcome Dr. Harold Morris. And Dr. Morris, besides being a good friend of the Hunters and a good friend of Paul Farmer, is the president of the ANMed Health medical staff. And he specializes in internal medicine and critical care, and he's frequently visited and worked in the Haiti situations with Dr. Farmer. So, Dr. Morris, please.
Thank you, and I'm very pleased to see this very good turnout. One quick announcement. This is an official CME accredited lecture for the physicians and any non-physicians who need credit for continuing education. There is a sign-in sheet back there, and you have to fill it out and fill out an evaluation, and if you'll do that, it's on the book signing table. I promise this is, ANMED sponsored this, and I promised I would make that announcement. Dr. Hunter, I consider to be a very good friend of mine, and even though our political views were very diverse, I think we had a mutual respect, and his friendship meant a great deal to me. I think most of you know what the Calhoun Lecture Series meant to Dr. Hunter. It was something he was passionate about, and I was delighted that Tom Tootin organized this endowed chair in his honor, and as we all know, he passed away recently, and so now it is in his memory. We had a lot of interesting discussions. I had the great honor of being his physician during his dying days in the hospital, and the two things, we were talking about a lot of end-of-life issues and whether he would go on dialysis and quality of life, and he didn't really want to talk about those sorts of things, but I knew I could always get his attention if I mentioned the Calhoun Lecture Series. He would perk up and those sparkling blue eyes would come alive, and he would want to know what the plans were and who did he think we should invite for this lecture. The other topic, of course, was politics, and I sort of like to tease him, and Jane thought I was cruel a couple of times to wake him up. I'd say, don't worry about anything in the United States, because when President Obama is elected, you won't have to worry. And he would wake up, give me this very steely look, and so anyway, I know Bill is here tonight in this room monitoring this discussion. And in thinking about Paul Farmer and Bill Hunter and what they have in common, I think they were two of the greatest physicians that I have had the pleasure of knowing and working with. They both had a very genuine concern for, love for, and empathy for their patients. And they both had an ability to project themselves into the lives of their patients, and the curious nature of Dr. Hunter, all of us spoke about earlier. And Paul Farmer also has a very curious nature. He relates very spontaneously, very genuinely to his fellow man, which is what makes him such an excellent physician. The other thing is they were both very passionate about their work. Dr. Hunter loved being a family physician. It's what he lived for, in addition, of course, to his dedication to his family, but he loved the role of doctor. And the first time I met Paul Farmer, I was convinced of that also. And the other thing, I never had a chance to work with Bill in a clinic setting or seeing patients, but I have worked with Paul on more than one occasion. And particularly when I first met him, and he was a medical student then at Harvard, he has a joy and a passion for his work that's very contagious, and he has an ability to inspire other people to join him in these missions. And I think that's something else that Dr. Hunter shared, and the showing of the patrons tonight. All of us patrons were there because Bill called us personally, most of us, and said, I need you to be a patron of the Calhoun Lecture Series. The thing about Paul, and I'll sort of transition into my introduction, I won't go through all of his academic accolades. We all know he went to Duke University and then to Harvard Medical School. But he is a physician or an individual who charted his own course, continues to chart his own course, and to defy conventional wisdom. The first example of this that I saw is when he was a medical student and he convinced Dr. Braunwald that he was an MD, PhD candidate, that his research would be in rural Haiti. And the traditional PhD, MD track puts a researcher at the bench doing basic science research, and Paul was able to convince Harvard Medical School that his work in Haiti was legitimate work toward a PhD, and I think that really was a new course that he was charting. The other conventional wisdom that he challenged was the dogma in the early 80s that you can't treat HIV in resource-poor settings. And this was the early years when the AIDS epidemic was progressing rampantly in Africa, and everyone said, we can't possibly treat this because the medications are too expensive and we don't have any way to deliver the medications. And therefore, the World Health Organization and the international community sat by while this epidemic became greater and greater and more severe. That's when Paul said, we can do this, we will do this, and he was able to demonstrate in Conj that you could quite successfully treat HIV in resource-poor settings. And I really think he personally deserves a lot of credit for the turning around of the World Health Organization to say we can do this, pressuring the drug manufacturers to lower the price of the antiretrovirals so that we could make this available to those in need who deserved it. So he's a wonderful role model for all of us in healthcare, for all of us who want to get involved and make a difference in the world. I consider him a great physician, he's a great teacher, and a very dear friend, and I'd like to introduce Dr. Paul Farmer.
Thank you. Thank you very much. It's an honor to be here back at Clemson, and also, of course, to give a lecture that honors Dr. Hunter. I did complain a little bit when I got here, saying, well, how come when I come back to the university, it's on a weekend where there's no football game and the students have all left? But I see some students are here, and I'm really grateful that so many people would turn out for this lecture. I had been advised by Dr. Harold Morse, that there would be a fair number of health professionals in the room. So, and he mentioned already continuing medical education credit. They actually forced me to fill out this little form that said, here's the 3 main points of the lecture. Thank you, Harry. I really appreciate that extra task in addition to driving 8 hours to get here. That was my fault, though, because someone told me that Roaring Gap, North Carolina, was right around the corner from Clemson. And about $191 worth of gas later, I found out that was not so. So I thought, how can we honor Dr. Hunter's memory, make everyone at ANMED happy with the CME requirements, speak to a general audience of people interested in health, and how could I talk with my friends from South Carolina who've been supporting our work in Haiti all in one seamless lecture? And I'm going to try to do that by using the example, actually, that Harry just mentioned, the example of AIDS, but also what's going on in Haiti, and then get back to some bigger questions. So, forgive me, I'll try to avoid medical jargon and public health jargon and really stick to the broader issues, which are not about any one disease. I'm looking at some friends of mine who are surgeons and anesthesiologists who are here. And the same holds true, of course, for surgical disease, or people who aren't in school who need to learn how to read and write, or people who don't have access to clean water. These are problems that we see all over the world, particularly in some of the places in which I work, but a number of these lessons are relevant to the United States as well, and I hope that during the course of the discussion format we'll be able to have an exchange about this. But let me keep on track. I put the little tiger paw on there, and I thought you guys would be happy, but again, no student reaction. I have to say, though, and I hope that the spirit of Strom Thurmond will not strike me down, that some of the, there's an awful lot of, it's almost distracting for drivers, or maybe it's just when you have a 1987 Grand Marquis rental, that you find those paw prints in the road unnerving. So I hope that the university will consider being less distracting. Even more frightening is that tiger's face peering out from the, we need an art consult here. Now let me go again from the specific to the general. So the specific, this is a time and place. This is where I met a lot of people from this part of the country, from Upper South Carolina. This is not Upper South Carolina, it's rural Haiti, and this was the largest river in Haiti, is the largest river in Haiti, and some decades ago was dammed to make a hydroelectric dam. And this happened all over the world, happened in the American Depression with the TVA around then. And these infrastructural projects can do wonderful things for people we know, generating electricity, which nowadays looks like a very good way to generate electricity. But of course, something invariably happens to those who live behind the dam. And these happen to be the people that I and people from South Carolina went to serve, a group of displaced peasant farmers, and that's a local term, peasant farmers, but small-scale farmers who were working the land along the sides of the banks of this river for time immemorial and had been doing this, and their parents and their grandparents and generations had been doing this. So I think in a way this was a great way for a young American to learn about the unintended effects of policy. And in teaching college students, which I don't do very much, but I'm doing now, this is one of the examples I give them when we want to talk about the unintended effects of policy. And of course, there may be good effects, but there are also invariably bad effects. And that's what was experienced by the people who I came to serve, and I'm proud to serve still, people of college. And let me tell you, and if this were a smaller group, and when we're using Socratic method, or teaching students, I might just say, well, what do you think happened to the people who live behind this, upstream of this dam? And you can imagine what happened was a very disorderly or non-resettlement process where people really left the land the day that their water rose, grabbing their kids and a little bit of livestock and going up in the hills. The first time I heard this, I didn't believe it. I thought it was Haitian exaggeration. But you heard the same story again and again, and you knew it was exactly as they described it, that they hadn't really been a part of this process, the people who lived behind there, and didn't know what was happening. And again, this is very instructive for a young medical student as well, who intended to spend a good deal of his time working in a place like this. How can we involve the community? That's a buzzword, but how can we involve the people who are living where we're going to be working? And that's what we tried to do some years later. Now, I really didn't mean to show this here, but rather across the street at the church. These are some pretty embarrassing photographs. I wish I had reviewed them a little more carefully before seeing them on the big screen. But back some years ago, I got to meet, this is the bishop from South Carolina, Upper South Carolina, William Beckham. And some of the people here know him, and my colleagues, friends, really kind of adoptive parents, the Fritz and Yolande Lafontaine. And that's me back when I had hair. And so this relationship goes back for 25 years between Haiti and South Carolina. And I want to talk about, I was across the street at the church yesterday, the Episcopal Church. We were reflecting this afternoon on the nature of our work over these 25 years, more than 25 years, the nature of our work together. And if we, after 25 years, could not look back and say, things are much improved, then of course we'd be, that would be a tragedy, because that's a lot of years and a lot of people involved and many resources as well. But the good news is we can look at the problems that we saw in the early 1980s and say those problems have been alleviated or addressed effectively. A new set of problems will arise, of course. That happens everywhere in the world. But what we are able to say in looking back is that it is possible to break this vicious cycle, to rupture this vicious cycle of poverty and disease. And that's an important lesson for young people today, too, because so many American students are interested in global health, interested in public health, and interested in development. And it's just something that 20 years ago, or a little bit more, when I was at Harvard Medical School, when we had a meeting about international health, maybe one or two people would show up, and I would be one of those one or two people, which, if you think about it, often meant that I was alone. And now about half of the medical school class has expressed real commitment to this kind of work, whether it be domestically in the United States or transnationally in other places like Haiti. So, but my point here was to show, I was looking for some pictures from 1983, and I saw some today that were some of my friends from South Carolina have. When we went there, following Father Lafontaine, this Haitian priest who'd been working in Central Haiti for some years, mostly on education, when we went there, not only was there no medical work going on at all, unless it was done by visiting teams like Harry Morris and others, but it was also completely denuded of trees. There was no solid structure for a school, to say nothing of a clinic. And I can get those pictures and I'll put them in next time I come back. But even a couple years later, when I could find in our archives, you can see that the top of this hill was really naked. There were no trees there. They were starting to build some buildings. Actually, this building is a place where many people from this part of the world who've been there have stayed. We call it Friendship House. But just a few years later, not a few years later, but there is, and these are some surgeons from South Carolina, actually Donnie Roberts, who's here now. But also, as you can see, the hospital has been built, and it's surrounded by trees that are 40 or 50 feet tall. In fact, I'm a sort of a pacifist by nature, but I almost slugged one of the Haitian doctors when he asked if we could cut down the trees around because it was too dark inside. I didn't really. And, this hospital structure has been much improved upon. This is back in 1994, 95 when we built a new one. It's now better still. So a lot has happened, and I just want to put this in as a general way of making the point that it is, if this work is done right and the money really goes where it's supposed to go, that an enormous amount of work can be accomplished in a fairly short amount of time. So, and this, by the way, was a recent picture. I think I'm going to have to choose a new one that doesn't have smoke coming out of it, by the way. I'm with one of my colleagues from Partners in Health here tonight, so note to self. But this place looks very different than it did just 25 years ago. And that's in the foreground, you see a new outpatient facility that was just completed last year. Now, let me go back to my specific example of AIDS. And as I said, AIDS is only one of several problems, and not anymore the ranking problem. Harry, in introducing me, mentioned that in the 1980s, it was threatening to become, and did rapidly become, the leading infectious killer of young adults and children in Haiti. So a huge problem then. He also said this was a time during which there was a great deal of pessimism about our ability to do anything in terms of taking care of people with AIDS. But as I'll show you, that pessimism, in fact, endured, and it's only been in the last several years that we've had a chance to counter that. Now, some of you who are teachers may find this useful. This is World Mapper. It's a computer modeling exercise that basically takes the globe, the map, and then the size of the country that you're looking at is the size of it is based on the problem that we're looking at. So you can imagine what if you were looking at access to clean water or access to safe motherhood, meaning where there's modern obstetrics. So and this is available to anybody. It's a what do they call that? Open source, and a very good teaching tool I've found. But this is what HIV prevalence does to the world. As you can see, HIV makes Haiti much bigger than the Dominican Republic, and of course, the continent that's most affected is Africa, where we have taken, as I'll show you in a minute, much of this work and brought it over the last several years. So that's what the world looks like if you're looking at the burden of disease, the virus that causes AIDS. Now, how about physicians working? Now suddenly, Africa is a slender ribbon of territory instead of a vast, enormous continent. And Haiti, of course, is small again. And you can see there are a lot of physicians in India, China, the United States, Cuba. But again, the disparities that we have to confront when we're thinking about responding to trying to rupture that cycle of poverty disease are enormous. But again, is this the beginning of a conversation or the end of one? Because if we're going to throw our hands up and say, well, there's no doctors and nurses looks even worse, by the way. There are no doctors and nurses. Well, there's nothing we can do. If that's the reason to show this kind of information, then there's not a lot of fruitful discussion to be had. But if it's the beginning of a discussion, then much can be developed. And one of the things we've tried to do is ask, first in Haiti and then much later in this country and elsewhere, if there are no doctors, one of the things we want to do is train doctors and nurses and other health professionals and keep them in these regions. But who else can be involved in this work? who in addition to physicians and nurses, can be involved in contemplating the problems of healthcare? And the answer, of course, is everybody. But specifically, we train community health workers, and I'll return that in a second. Now, I want to show you a couple of examples of the kind of thing that we saw in the medical literature. And I'm just curious, how many of you are physicians here or nurses? Not so many. So I'm assuming that the rest of you do not read every week the Lancet. And, you know, it's funny that I noticed that doctors kind of have downwardly mobile names for their medical journals. The Lancet. It's not a very appealing name for a medical. It's not something you're going to run out to the store, you know, the corner convenience store, and say, "Oh, I need to get my latest edition of People and the Lancet." You know, actually, and this is one of the premier medical journals. The gastroenterologists of the United States, the name of their ranking medical journal is Gut. So it's not just one journal. Anyway, that's not the point. It's a very prestigious journal, and in 2002, right before the Global Fund, which became the first financing mechanisms for AIDS treatment and tuberculosis programs, malaria control, first multilateral financing mechanism, you can see the kind of discussion that was in the medical literature. And I won't read these to you, but again, I'll ask that question. Is this to start a conversation about how we can treat AIDS in resource-poor settings, or is it really meant to discourage contemplating how it would be done? Now, for those of you who are not in this line of work, HART means highly active antiretroviral therapy, which is to date the only treatment that we have for this particular lethal wasting disease. And what it does is a lot like insulin for a diabetic. It doesn't cure AIDS, just as insulin does not cure diabetes, but it makes it a chronic, manageable illness and not a death sentence, which is what it was, which they both were, of course, diabetes, insulin, type 1 diabetes before insulin. So this is a specific example, but of a very general problem. And as medical technology improves, as medicine and public health become potentially more potent, we're going to have to face this problem again and again with all of the effective deliverables, that is, whether they're preventives or therapeutics, that come online through whatever mechanism, usually developed by basic science research and discovered through basic science research and developed by the pharmaceutical industry. Now here's the specifics again. This is real data, not from computer models. This is, again, ART, I remind you, doesn't matter what it means, but it's the treatment for AIDS. And here are two different regimens. Again, the specifics are not important. And there are three sets of information. One, the average wholesale price of this regimen per patient per year in the United States. Two, what Partners in Health, that is what we were paying through a mix of concessional prices and generics in 2002, again, all the same year. And then three, what the International Dispensary Association, which is the world's largest nonprofit procurer of pharmaceuticals in the world, based in the Netherlands, what they were able to, the price they were able to negotiate. So as you can see, confident claims about whether or not a certain intervention is cost effective have to be interrogated by the fact that the same regimen costs such radically different, can be had somewhere in the world for such radically different prices. And again, just now, 2008, only 6 years later, the same regimen costs around $90 per patient per year. So this is not a static, or this is a moving target. And of course, it's not moving because of, I was about to say because of Wall Street bailouts, but I'm not supposed to talk about that here. It's not a moving target because of some, say for example, that the materials used to make these medicines are somehow rare and difficult to find. It's because the pricing of pharmaceuticals is a very unusual process that is not sculpted only by market forces. And I'll return to that if we have time. Now, that's what it looks like on the large scale. But what's it like to be a doctor going, as I was, between Harvard and Haiti? And when I was training as an infectious disease specialist in the mid-90s, after I had completed graduate school in anthropology and medical school, I was aware, of course, of the development of these drugs and how they worked if you're in that line of work, you would have heard about it before anybody else did. And I remember asking myself, how long before the efficacy of this intervention was proven, how long before people in Haiti, my patients in Haiti, would be asking me how I could get that? And the answer was no time at all. In fact, I came back from the meeting at which some of the early results were presented. This was in Vancouver, which is in a country to the north of us, below Alaska, which you can see from Alaska, in fact. But I was in sorry, I'm not violating any rules, am I? I went from Vancouver to Haiti, and all right, I got to stay on track now. I went from Vancouver to Haiti, and in the airport, someone said, "Hey, doc, how long before we can get these medicines?" And so there I was, on one end of that trajectory, begging my patients to take these medicines faithfully, and on the other end, being begged by my patients for these medicines. And I would argue that that is not a psychologically, emotionally tenable situation. You can't say, oh, I'm back in Haiti, suddenly it's not cost effective to treat patients with AIDS, or it's not feasible or not sustainable, and on the other side, just a few hours away, 3 hours away, I'm making a very different argument. And I would never recommend to any of my students that they try and jump through all these hoops, these explanatory hoops to tell people, gee, I'm sorry, we can't do this for you. Better just to apologize and say, we're working on it. Because I've never in all these years working in Haiti had someone come up to me and say, oh, I have AIDS? Well, it's too bad I'm a Haitian woman. It's not going to really be cost effective to take care of me, so why don't you go back home? Nobody's ever going to say that, and no one ever has. And so it is with my friends who are surgeons or anesthesiologists who work in Haiti. They don't hear that either, and that's not how humans think, and certainly not how family members think. And now I mentioned family members because this is what it's like for a family. This is a young man and his mother, of course, and he's 26, and the story that he told later, not now, not at that point, was that he'd really given up. He'd been in Port-au-Prince and went home to central Haiti to die. And in fact, had already been resigned to this. But his mother convinced him to go to the public clinic that Partners in Health had recently renovated. And I'm putting the dates here because it's important. And the reason it's important for him is obvious. When we received the funding for this rehabilitation and training and these medicines, he would have already been dead because we were promised this money in August of 2002, but it didn't arrive until the late spring of 2003. And I would argue you don't have to be a doctor in search of continuing medical education credits to guess that this man is not long for the world if he doesn't have the right care. Now, he had tuberculosis and AIDS at the same time, which is classic. I've told this story before. I'm going to risk telling it again since I've never told it in Clemson, that the person who took this photograph was a student of mine, now a colleague. He was from Harvard Medical School. Actually, some of you saw him on 60 Minutes. This is the young physician who spoke so compellingly about his work in Haiti. His name's David Walton. And I was in Conge, where I'd been living, which is about an hour and a half away, and he was in another town, Las Caobas, which is the hometown of this young man, Joseph. And he wrote me an email saying, Paul, can you come and see this patient for us? He's 26 years old, and he went through all the information. And I wrote him back saying, I'll be glad to, but why don't you guys take care of it? I mean, you're well trained, and the Haitian team is superb. Now, what I wanted him to say, of course, is, well, because Paul, you are the world's greatest infectious disease doctor. Now, I ask you, Socratically, do you think that's what my Harvard medical student replied? He said, well, we just want you to come and cheer him up. Now, and I said, what am I, clowns without borders? Now, that is a true story, and I made the mistake of telling it a few months ago in New York City, and afterwards it's at NYU. I rest my case. And some people came up to me and said, Dr. Farmer, we're from Clowns Without Borders, and we wish you'd stop using this anecdote. In any case, I went to see him, and I told him, you should take these medications. I've seen people sicker than you get better, which is true, if barely true. And I'm glad I did, and so was his family, because just a few months later, he's a new man. Or I would say, oh, you're a new man, Joseph. He said, no, I'm the old Joseph back. And this guy is also on that 60 Minutes piece that some of you may have seen just a few months ago. And so I asked him, of course, can I use these pictures in my public speaking to talk about the power of some of these interventions? He said, sure, it's not like I ever get invited to them, give these lectures. I later got my revenge on him for that, as you'll see. There he is, giving a lecture with his own pictures behind him. So I sent this off to my colleague Jim Kim, who's at the World Health Organization. And, you know, Harry was good enough to credit me for the turning things around. And, of course, it was really the patients who responded to this therapy and who made the case for us. But Jim was off at the World Health Organization for 2 years from Partners in Health in Harvard. And he put this into the World Health Report, which, like the Lancet, is something I'm sure you guys read every year. You never miss the World Health Report, do you? So this is the strategy. Remember the question I was asking, when you don't have any doctors, you have very few doctors, who do you need? And the answer is a community health worker. And I'll return to the United States in considering this. But there it is. There's the model. You know, it's, as they say in certain parts of the United States, it's not nuclear physics. So there's the model. A patient with a chronic disease, could be bad hypertension, diabetes, you know, and there's his community health worker. But there's more to the story. Then you have this young man brought back from the dead who suddenly is a very zealous participant in AIDS prevention work. And that's what he's doing here in front of quite a large crowd. So I said, when I saw this, I said, I'm going to bring it back to Joseph. And I brought it back to Haiti, gave it to him, he opened it, he looked at it and said, yeah, I'm a star. Now, here's for your CME credits. Don't worry, only a few graphs. I should be done in an hour. So this is the town, this is the clinic. Now, the first picture, you'll have to take my word for it, was taken at midday on a weekday in August 2002. And that's what it was always like there. It was padlocked. What little work that was done was over by noon. No doctor there. A nurse, an LPN, a nurse assistant was there, doing yeoman's work, really working hard. Mostly what she did was around vaccines. But there's really no reason for people to go there if there's no services there. And so we went in, and this is, I say with Global Fund money, though I've already told you we didn't have Global Fund money then, we'd been promised it. And so we ended up taking a loan out of a commercial bank. And again, some people said to us, you're taking a loan from a commercial bank? You know, I was laughing yesterday because people were talking about a certain hospital in Florida and calling it a loss leader. I said, isn't that what hospitals do? They spend money and sort of lose money. And we're under a lot of pressure to behave like businesses. And some of we hospitals, for example, but some of this is smart, like better administration, better management. But some of it is not so smart. We can't pretend that we're going to go to Haiti and not be lost leaders. I'm kind of proud of that. I think that's what we should be doing. And we said we've got to bring in these basic laboratory, we have to improve this, and I'll go back to at the end and show you what it looks like now. But of course, once we put in the services, even before we did much in the way of improving the infrastructure, the place became jam-packed. And some people here have been there. And you know, you'd go from, I'll show you the numbers for CME credit. July 2002, why bother going to Las Calabas Public Clinic? Why not just take a rickety public transportation that's dangerous all the way to Conge, 2 hours away in the local transportation? And the answer is that's what people were doing. 2 truckloads a day came from this city up to Conge, and that's not smart, and it's also not even safe. So, but once we gave them some modicum of decent care, of course, this place filled up. Now, here's some interesting things. Not only were we able to, and I meant to show you some data from prenatal care, family planning, and vaccination distribution. Of course, when you have a clinic full of people and you have good preventive services or other services they need, suddenly you have people interested in what it is you have to offer. So all those good things happen. But here's another part I want to get to. When I was in that clinic, before, or the hospital for that matter, before we had some of these treatments, and I'm just talking about AIDS, we used to hear patients say, I can't stand up, I'm sick, I can't even swallow my food. They were very, very sick. Sometimes they'd be carried in to clinic, not to hospital. But once we got them on the right medications, they didn't stop complaining. That's what patients do. In fact, we call them complaints. What is your chief complaint? I never thought much about that. Maybe we should think of a new way of addressing patients. What's your chief complaint? But they didn't stop complaining, but they didn't complain about symptoms. They said, my kids aren't in school, and my house, when it rains, the water pours in, and I'm hungry. And you look at this in one of two ways, I've found. One is you can be annoyed. You can say, well, I didn't go to medical school and do an infectious disease fellowship so that I could hear people talk about agricultural prices or their housing. Or you could say, you do good work in one area, and you get to see all of people's problems revealed, and then if it's the beginning of a conversation, you can make a compelling intervention. And of course, that's what we strive to do in our everyday work. It's not always easy to keep that attitude. It's much easier to say, well, that's not my job, or that's not my bailiwick, or that's not my training. But they didn't come to see you because they, they didn't come to see us because they cared about what our particular interests were or training background was. They came because they had problems. And learning to listen to people and learning to appreciate that this is your chance to enter their life worlds and do something meaningful with them rather than to them, I think is one of the best things that I've done, and one of the things that's kept me passionate about this work. And so we ended up linking our work. Again, this again, it was a gift from the people of South Carolina, this water project. This is from many years ago. But also thinking about mobile clinics, primary education, adult literacy. How many of our patients, when brought back from the dead, said, I want to learn how to read and write? A lot of them. Working on housing improvement. Actually, this will make some of the old-timers in terms of coming from here to going to Haiti smile, because this is a group of high school students from Conge who now realize, after 15, 20 years of our collective work, that they're not in big trouble like people from other towns in Haiti. And so here they are volunteering to rebuild someone's house on their high school break. And that also is part of this virtuous social cycle that we want to talk about. How can we bring not only people like Joseph into this work, but how can we bring young people whose problems are still severe, but nothing as severe as their parents were, into the work? I want to pay tribute to some friends from here in South Carolina as well, who are here tonight. The short-term responses to malnutrition are kind of obvious. It does not take, well, actually, maybe to some people they think it does take, but it doesn't take a 10-year-long NIH study to discover that the treatment for malnutrition is something called food. But sometimes in these discussions I've had with my friends in public health, you'd swear that we have to show that food is necessary to treat malnutrition. My mother has tried to coach me, and she said, well, honey, sarcasm is never a good thing. You've got to find a non-sarcastic way to respond to that. And I'm still trying. Bless my mother. But you know that the short-term intervention is clear. You have a malnourished child, you need calories, you need protein. And we know how to do that. We actually, with help of friends from South Carolina, in fact, we make a ready-to-use therapeutic food to treat adults and children with malnutrition. But that's not going to address the root causes of hunger in Haiti. That's going to require thinking about food security, agricultural initiatives, some of which we're doing with people from Clemson, fair trade policies. And this is a very painful subject for a lot of people in the United States and Europe, because our trade policies and our agricultural subsidies, of course, undermine the ability of small-scale farmers in Haiti or Africa to be part of the solution. And also, of course, and I'll return to this at the end, which is approaching deforestation. I didn't mean it's approaching like end times. Sorry. Now, can this be scaled up? This in question is this more comprehensive primary health care. Well, we've scaled it up, I think, across Haiti from the Dominican border all the way to the coast. And so, although a good friend of mine who's involved in this kind of work said to me after I showed him this map, he said, well, that's not really scale up. I said, it's not? I was, shaking. He said, no, that's, what do you call it? Incremental something or another. And I said, okay, well, that's good, though, isn't it? And scale up is usually taken to mean a national level scale up. And, oh, no, he called it contiguous spread. That's what it was. Sounds like an epidemic. But if it's an epidemic, I guess it's an epidemic of goodness, I hope. Anyway, this is a lot to do in 10 years, to go all these places where there's a red dot. There is a public facility, with the exception of Conge, where we all started, many of us. There's a public facility that has been redone, and local people trained, and sick people getting care in each of those places. About 1.2 million population, and last year alone, our Haitian colleagues saw over 2 million patient visits. So this is a huge. We're the largest provider of healthcare in rural Haiti, certainly, all having exploded over the last 10 years once we started working in the public sector. And more on this. What about one of the, it's funny, when the discussions of scale up are meant to stop the conversation, which I see all the time in public health, people will say, okay, well, you scaled it up in Haiti, which is an easy place to work, right? But how about Africa? And, for us, when we started having this conversation, actually it was the Clinton Foundation and President Clinton who said, you guys have to work in Africa. And one of the first places we started was in Rwanda. And we knew when we went there that we had to do three things at once. We had to rebuild health infrastructure, we had to train local people to do this work, and we had to provide care for people who were already sick. But when we went to Rwanda in 2004, we started the work in 2005, we had something we didn't have 20 years before. And we had the Haitian team, the Haitian doctors, nurses, even a priest, social workers, pharmacists. They had done this now several times. So they went with us to Africa, to Rwanda, Malawi, and Lesotho. And I think those of you who have watched this wonderful flowering of human potential among our Haitian coworkers should be very proud, and I know they are, of what they've been able to do in Africa, our Haitian colleagues. Now, we went there in 2004 to the northern part of Rwanda. This is one of those lasers, right? We know at Harvard they've taken this away from me because I keep pointing it at the students. And the AV police came up to me and said, Dr. Farmer, please don't point the lasers at the students. So now whenever I stand at the lectern, they've removed it. Oops. Help. Oh. Maybe it's this. The top one? You've done the same thing? Of course, I might ask Harry. Yeah, I might ask why, well, he's got a terminal degree in nerdiness. The thing about these lasers, they really don't add anything, right? What am I going to do? That's another thing is, notice how professors, the more close they are to tenure or after tenure, the more they squiggle it around. But we went to this town, Ruangari, in the north, and it's where some of you have been there. Actually, it's where you go to see the gorillas, which I did too, looking in exactly this suit, by the way. You can imagine the European eco-tourists looking at me and the gorillas looking at me and said, what is with this guy? He wore his dress shoes to climb a volcano. But I didn't know I was going to see the gorillas because I wasn't looking at my schedule. I thought I'm going to the hospital. I went to the hospital. There was electricity, x-ray machines, and 3 doctors. So I went back to the capital city. Harry, thank you for this, by the way. Can I shine it on your retina? Anyway, so I went back to the capital city and said to the director of the National AIDS Program, and again, this was not an AIDS program. It was a comprehensive primary health care program with surgery in it, too. I'll show you in a second. And I said, well, we're from Partners in Health. We're tough. You can send us to a more difficult place. Now, I've later, in retrospect, diagnosed this as public health machismo. And so she said, okay, I have just the place in mind for you. So we went to Ringwavu, which had been abandoned since the genocide, and there was no doctor there. But we had our 3-part plan: rebuild infrastructure, train local people, take care of sick people right away, not in parallel, do this all at once. And of course, we had our Haitian colleagues with us. And again, it's not nuclear science. This is the way it looked before, and this is the way it looked a few months later. Inshuti mu buzima means partners in health in the local language, Kinyarwanda. And it's true we didn't have a lot of doctors, but little by little, people said they'll never go to rural Rwanda. They don't want to work in rural Rwanda. But they did, and they are. And we rebuilt the infrastructure. Donnie, do you like? Which meant redoing the operating theaters. Probably that maybe you gave me this anesthesia machine. And we trained lots of people. And we saw the same, it's funny, when the Haitians came in and said to their Rwandan colleagues, buck up, you can do this. We did it, you can do it. Somehow it's more compelling, I think, than coming from me. Because they could say, we had no optimism about this in our country either. We can do it. You're going to have your Josephs too. And they didn't say Josephs maybe because they had so many people. But then this guy comes along. His name's John. He also has TB and HIV. And, this is after a few months of treatment. He goes from Skeletor to needing Lipitor. So, and it's not just adults. You meet kids like this for reasons that are not entirely clear to me. That everybody at the hospital calls this girl J-Lo. I think she it certainly was. Never mind. That's definitely what I was going to say. Is definitely not appropriate for prime time. Anyway, it's a good story because everyone said, well, she's an orphan and she was abandoned here, but she wasn't an orphan, and her mother had left her there because she didn't know what else to do. But we knew what to do. We knew that she had AIDS, tuberculosis, and malnutrition. We could treat all three of those things even at the same time. And guess what? Her mother came back and said, she's my girl. That's my child. And now her mother works with us on treating malnutrition and preventing malnutrition. So a lot of good things can happen when you do the right thing. And I'm using examples largely from my line of work, but it's true, I think, of lots of other interventions. Now, this is CME type thing, but using this community-based model of care, making sure that community health workers are able to provide these services in the community, not in the clinic and not in the hospital, we have much better outcomes than we see in the United States or Europe, much better. And that's shocking to some people. It was a little bit shocking to my colleagues in Boston, and I wanted to skip ahead when I said, okay, we need to have a project like this in Boston with community health workers going to people's homes and helping them. And but I got in a little trouble because I said, well, all we're trying to do is raise Harvard levels of care up to Haiti levels. I did not get CME for that, I'll tell you. But in order to open up a discussion, I just want to say some of these lessons learned in Haiti have been very applicable in the United States and elsewhere, certainly in Africa, but in our country too. And maybe some people will want to talk a little bit more about this. Now, the big challenge, and again, I thought that if only there had been a football game this weekend, this place would be full of students. And I'm not complaining; it's still full. But as I said, this generation, which I heard some pollster calls them the first globals. Zogby, I guess is his name, just wrote a book. I didn't read it, but I know in that book I will read it, I promise, Johnny. I will, I promise. You can still quote a book even if you've not read it, right? I'm told that's done a lot in American politics. But he calls them first globals, and this is the 18 to 29-year-olds maybe, and certainly my students, both undergraduates and medical students, and some young physicians in training too. This is a generation that expects to be global, and certainly what's been happening with the financial sector is another reminder, just as is an epidemic disease, that we are living in a global era where and the good side of it is this generation, they'll be the best ambassadors we could ever have as a country. I believe that. And but they're going to have a lot of problems because what has happened in many places in the world is a great decline in investment in public infrastructure. And that means public health and public education. There's not a lot of doctors or nurses, but there's also not a lot of support for community health workers. So when we do develop new medicines and vaccines, like a vaccine for tuberculosis, HIV, malaria, just to go into my line of work, we're still not going to have a system in place if we don't invest more heavily in primary health care. And that's one of the points I wanted to make for the physicians here. Now, I can't close without talking about what I saw, and some of you have also saw with your own eyes, which is the devastating impact of 4 hurricanes in 1 month in Haiti. Now, I can tell you that even though we saw a lot of bad things in central Haiti, for example, in 26 years, I've never seen Highland Haiti, the town of Hensh, flood, and it did. The next picture, I think, is from Hensh. This is Hensh. This is not the coast. This is the central plateau up in the hills. So I'd never seen that happen before, but a lot of good things are revealed as well, at least as far as what we saw our Haitian colleagues do. Again, if after 25 years, the entire country was incapable of responding to these hurricanes, including our team, that would be bad. But I would like to brag about my colleagues. These are my colleagues, a social worker and 2 community health workers, wading out into the water looking for people. And all over central Haiti down to the coast, our coworkers were involved in responding. But that said, and again, also in the areas where we reforested, which is not enough, but Conge did not have, for example, this devastating erosion. That's the crux of the problem, is that Haiti is deforested. So just as food security will require an investment in reforestation, so too does security, no matter how you parse it. Security in general, we have to have this broad approach to addressing poverty in Haiti and elsewhere. And we have, I think, a chance, and what we have been able to, what we try to do is to say, look, people from all different backgrounds, hearing Harry tell about his sounded like animated discussions with Dr. Hunter, but people from all backgrounds, I think, can agree that, and all faith traditions can agree that when someone is sick and in need, there's a lot that we could and should do. And that unfairness and disparities in healthcare is unacceptable. At least it's unacceptable to the Americans I meet, no matter where they're from or what their backgrounds are. This is something that that's why I think this global health movement among young people is so powerful. AIDS has been a good example for them. They heard about people saying, well, there's nothing you can do. It's just too complicated. It's too difficult. It's too expensive. Young Americans heard this and said, really? Is that the beginning of the conversation or the end of it? Met a group of students at Stanford who a few years ago, maybe 3 or 4 years ago, invited me to Stanford to give a talk about Rwanda, actually, and healthcare. And they said that they were going to raise $150,000 for Partners in Health that night with a dance-a-thon. And I said, what is a dance-a-thon? You dance for 26 hours? What? And how does that raise money? What's the political economy of dancing for money? I mean, I know about it from Florida, my youth in Florida, but it's not sort of with a pole, and it's not something you could do at it. So I was skeptical, but the next day they had raised $150,000, and that group spread across the country. Face AIDS, it is called, and they have raised for Partners in Health over $1 million. These are 18 to 22-year-olds. And there are probably now over 100 chapters of Face AIDS. And I'm looking at a friend of mine who's in college now who's going to be starting you did know you're going to start a chapter, didn't you? Here in this part of South Carolina. And this says to me something very important about what's really good about our country. Is a very generous country. 45% of American households responded to the tsunamis in Asia. No other country could say that. But how can we coordinate our efforts in a place like Haiti, for example? How can we build Haiti back better after these hurricanes? To do that, we're going to have to not do business as usual. We're going to have to think very hard about integrating our work with the work of others, integrating our work into public health and public education, and thinking about being part of a broader movement for equity in healthcare and education. And I really believe that that's where we're going. And I'm very grateful to the people of this part of South Carolina for having me back here and for working with us for so long. Thank you very much, and I look forward to our discussion. Where are my fellow panelists?
Want to take the center seat?
What's that?
You want to take the center
Okay,
seat?
will do.
Okay.
How are you?
My name is Rosemarie McDonald, and I'm one of the physicians at Clemson University. I represent 25% of the physician pool, since there are only 4 doctors at Clemson. Tonight, we have certainly enjoyed hearing what you had to say, Dr. Farmer, and we thank you. I think we'll hold this down to just a few questions, and that'll allow you a time to have your book signed and maybe say a word to Dr. Farmer. So I'm going to start with a question, and also I'm the Tom Brokaw of the
Right,
evening.
I saw that.
Okay, okay. And so I have a 4-minute question, and you have a 2-second answer.
Do I walk around?
Yeah.
Do I walk around aimlessly?
Yeah. We won't go there. Okay. My question to start tonight is, in view of our current economic situation and potential worsening, discretionary income that people may have in the past been giving toward charitable donations may come to may scale down. How do you see that impacting the work that you do in other organizations? And is there any place that things can be scaled down and still function?
Well, I think that's a great question. It's one that I've heard a lot this past month or two. And I will say one thing. For some people, this isn't really discretionary. And you look at the notion of tithing from religious communities, it's not the same. You'd think more about driving or getting a second car as discretionary than contributing to good works. That tradition is not dead in the United States, I don't think. And I'll give just one example that I'm very proud of. Partners and I sent out our first action alert after these hurricanes. So we knew we didn't have the resources to respond effectively because we hadn't set aside for a very rainy set of days. And so we did what other charities do. We sent out an action alert. And I think we had about maybe 6,000 emails. We have 22,000 supporters, but we had handy, I forget the number, maybe my colleague, Ali, who I'll introduce in a second, will remember. But we sent out the alert, and I'm told by my colleagues at Partners in Health who are experts in development that if you get 2 or 3% to respond, now remember, this is during the height of the financial meltdown, or maybe we haven't even seen the height of it yet. Or let's just say this was recently. I'm told that if you get 2 or 3% to respond, that's a good return. 60% of the people we solicited gave us money. And this is including middle-class families and well-to-do families, and some people who are neither, who are poorer, who believe that this was a good thing to do. So that says something to me. In the middle of a downturn, people can still look at someone else and see that they're in a worse situation. And that is not a dead tradition either. So yes, I'm worried about it, but I also have a deep faith that if we build our work correctly, not to just look for donors, but actually to try and build a community of concern who care about these people and other people that I've never met before as a matter of principle, I think that we'll keep going. I have no doubt there'll be a downturn in charitable giving. I just don't want it to affect us because I think we're looking for something better and a deeper commitment than that.
Okay, thank you.
Thank you.
Catherine?
Okay, I'm a new faculty, in anthropology, and we are working very hard right now to develop an anthropology program here at Clemson. So I thought maybe you could just talk for a second about how anthropology has helped you do your work, and then maybe comment on how we can use an anthropological perspective or historical perspective to think about the U.S. and Haitian relationship as it's developed over time.
Thank you very much. By the way, Catherine told me when we were sitting down having a bite to eat outside, she said, well, I tried to get my students to stay here, and I assigned to them an article you wrote in Current Anthropology, which, again, I know you guys read every quarter or every month. And I said, which one? And she said, An Anthropology of Structural Violence. And I said, that is not the article I would have chosen to bring those Clemson students in. Is that why they're not here?
Well, there's a few of them.
But, anthropology, as some of you know, is a discipline that's very focused on the way that culture works in our lives, on understanding social context. And as a physician working in Haiti, I'll just say a couple things. One is that doing a doctoral degree in anthropology, focusing on Haiti, led me to read many things and understand many things that I would not have been able to do on my own. It's just, most people do not have the discipline necessary to, read a huge corpus of literature. I know I did. I wouldn't, unless forced, I would not have done it. So I have a gratitude for my knowledge of Haitian culture. A lot of it comes from anthropology. I know that because I know people who've worked as long as I have in Haiti and really don't have that deep understanding of social context because they haven't read these works, they haven't looked back at history, etc. But I've worked in 10 countries, not 2, not just the United States. In Haiti, I've worked in 10. And I don't have the kind of cultural and linguistic knowledge in Rwanda or Malawi or Lesotho or Russia or Peru, for that matter, that I do have in Haiti. So one of the things that anthropology has taught me, and I could recommend this strongly, is it's made me know what I don't know. And I'm not quoting a recent Tom Brokaw-mediated presidential campaign. I heard that too, though. It's made me know what I don't know. It gives me a deep respect for the gaps in my understanding of these other places. And I think that too is because of my training in anthropology and that deep experience in one place. Now that said, when you know what you don't know, you can take steps to make sure that that ignorance, that lack of knowledge, does not hobble your response, and I think we've been able to do that. So for those of you interested in anthropology at Clemson, I think whether you're a legal professional or a teacher or a legislator or a doctor or whatever, or moving a business from France to Greenville, South Carolina, I'm sure that understanding what it is you don't know is a very important thing. So I'm glad I did that. How'd I do?
Right on.
You have 2 seconds left.
No, we can take another hour.
I have another question, and this one, I want to talk about the coordination of services. Many organizations, they may be religious organizations, other charitable organizations, make donations, they send workers, they send volunteers throughout the world. And sometimes those are grouped together geographically instead of spread out over an area. Do you have any comments to make about what your observations have been? For example, sometimes the Germans, the Swiss, the Americans will all end up in a little village instead of being geographically distributed. Are there ways to manage that? Have you seen?
Well, unfortunately, they always end up in a big city, which is the capital city. Although it would be interesting to see if they did end up in a village and how they got along. I would say that this problem is the leading problem in our work, and it will be the leading future challenge to this generation I mentioned. How can we coordinate and have sensible plan for attacking complex problems like these? I don't want to say donor nations. That sounds so chilly. But as people who want to be involved in this work, it's the biggest problem. It's, this 1,000 points of light approach is not good for public health and public education. Coordinating with local authorities, coordinating with each other is difficult. It takes more effort, but it's the only way we really will have sustainable development. Now, and I know I don't have a lot of time, I did hear that, but to compare 2 places, in Rwanda, the government is firm about, they insist that this be done. And I think they're right to be that way. And they've already been through hell. And they've already had an era after the genocide, which happened in 1994, in which everything was all over the map. And they decided that they would ask a lot of NGOs to leave Rwanda. And they got nothing but bad press for it. But I'll give them a little positive press. I think they did the right thing. They said, you get in line, or, the airport's over there. And as a friend of mine from Burundi said, they all went to Burundi. And he wasn't celebrating their arrival. Haiti, on the other hand, doesn't have that capacity really to coordinate and needs it, and we should help them. I was talking with my friends from the Episcopal Church. We should accompany them as they try to get other NGOs, church groups, to be part of this plan to have sustainable development. And that, again, for those of you who are students, is going to be the biggest challenge for the future.
Okay, thank you.
Let's see. So we've talked a little bit about the U.S. presidential election that's coming up, and we've heard a couple different ideas on healthcare and reforming healthcare in the U.S. What do you think is the single biggest barrier that's preventing healthcare access to millions of people in the United States? And what's the one thing we can change?
Well, right now it's the way insurance is structured. And why are emergency rooms the default providers of primary health care to the poor? It's because they're mandated to do so by legislation. It's illegal to dump people or to turn them away if you receive federal funding, which most hospitals do. And so the biggest challenge is health insurance. Now, I'm not an expert in that arena, but just as a provider, and as an American and as someone who, as an anthropologist too, who looks at, and a teacher of medical students, we are both, we spend more money per capita than any other country and twice as much as many industrialized democracies. And we have 47, 50 million people without health insurance. I've been told by people who know more about this than I, and I believe it, that by increasing access and moving towards universal access will also decrease health costs. Now, that hasn't really happened yet in Massachusetts. When in Massachusetts, healthcare insurance became mandatory, it did improve access problems, which again is a huge social gain, I think. Certainly if you're someone from Massachusetts, it is. It hasn't dropped healthcare expenditures yet. So that you're going to need to do more. You're going to have to increase efficiencies, increase, people are making fun of the candidates for talking about electronic medical records, but they're right to do that because that's a way to decrease the number of medical errors that are made. So I think some of the things that are on the table now about health insurance, about increasing access, are a way to move forward. Others I'm very skeptical about. I mean, 80% of Americans who have insurance are some way covered through their jobs. And the idea of removing that entirely seems, again, to a layperson who's a doctor who's not an insurance specialist, seems like a bad idea. I hope that doesn't happen because I'm worried about some precipitous drop in the amount of people covered if we do that. So, how'd I do? I keep asking her.
We're going to vote for you. I'm going to ask one more question, and then Catherine will have the last question. An article I read a couple of weeks ago in JAMA was written by a bioethicist and an infectious disease fellow, commentary on sending students primarily to needy areas for short-term experiences and the risks that are present to both parties when you do that. We, if you use Americans as an example, have risks when we go abroad to do this work, and yet the people who receive us are at risk as well because they may have expectations that we're trained beyond what we really are, and we may not do the work that we were sent there to do. Do you have any comments to make on that? I guess it really boils down to who should go and who should stay home and write a check.
This is a really serious one. Actually, Harry Morrison and I have been talking about this for 20 years. And I will give my most unvarnished, straightforward answer. When we start asking that question and publishing those sorts of things in the medical journals, I think it's a positive development because short-term medical missions are really very difficult to do. Now, I have argued over the past many years that the most straightforward area is subspecialty surgery or general surgery because it is not so culture-bound as almost all the other interventions. If you get a group of people in to do laser prostatectomies in central Haiti, as long as we're lining up the patients and providing good post-op care, that is an uncomplicated good, right? But when you start thinking about, and this is a question I get all the time about Rwanda, an American psychiatrist or a student of psychiatry or psychology goes to Rwanda, there's a huge burden of unmet need. Right. The big question, as you're saying, is, but can this person meet this need in a short amount of time? And I think the answer is no. Now, that doesn't mean that they should stay home and write a check, although that would be most welcome in the economic downturn. But finding ways to be involved in, again, training local people, building up local infrastructure, and making sure that your partners are able to provide these services is much better than what I did when I was, a young man. And so what we're trying to do in our work is to say, if you, as a student, say a medical student, are committed to this work, we will work to, make you be something other than a spectator to poverty. Because that's what it happens to be too often. Send young Americans or young Europeans to these things. They don't have the tools they need. They don't have a procurement team. They brought medicines that they're not authorized to disperse and that are not, they're not sustainable in the sense they're not generic. Right. So, working to address this whole system and letting students and short-term volunteers fit into a sustainable structure is going to be another one of those big challenges. But at least the conversation has improved now compared to 20 years ago. So, it's a great question.
Thanks. And Catherine, we'll let you offer the last question, and then after that we'll adjourn.
But I'm not really leaving, right? I'm
No,
staying.
yeah, you're staying.
Well, let's see. I thought we could talk some more about the hurricanes that we've seen in the past hurricane season. On NPR, they were talking about the deforestation and what a big impact that's had in Haiti. And they were talking about how you couldn't just plant trees, but that really it's this underlying poverty that people don't have other fuel sources that's led to so much of the problems that we see as the result of these hurricanes. So I thought maybe you could just talk more about
I'd be glad to, and I'm actually going to go back to the anthropology question that you asked in thinking about trees and what's happening. I believe that it's not true that Haitians don't know why it's bad to cut down trees. I know that's not true. Mm-hmm. So any intervention that only goes there to chide the Haitians for their disastrous ecological views is doomed to fail. It won't work because Haitians are cutting down trees because they have no alternative fuels for cooking their daily food. Mm-hmm. And a friend of mine who's here today has been working with a number of agronomists and local people in Haiti, some folks from MIT, to actually, instead of just saying, don't you people know what you're doing? But actually saying, okay, we're going to help you plant trees, find alternative sources for cooking, and above all, and here's the rub, here's the difficult part, is you need to create jobs outside of the agricultural sector. Mm-hmm. So even in healthcare and education, which is what we've done, which is not a long-term answer for 20, 30, 40, 50 years more, we still need jobs in Haiti outside of the agricultural sector, but productive jobs beyond healthcare and education, which are still productive. For example, light manufacturing perhaps. Mm-hmm. Because people are being pushed by population growth, so that's part of the cycle too, lessening that. And one way to do that is to make sure that children who are born survive to adulthood. Mm-hmm. Families lose too many kids, So bringing this all together, planting trees, finding alternative fuels, finding alternative employment, taking on both unbridled population growth and tragic deaths of children, pulling that all together in one meaningful package is again, I think that's where we need to move things forward. And unfortunately, there's a lot of balkanization. I have a friend here from Haiti who I saw tonight, who's here tonight, and I said, this American term, balkanization? He said, it's not really an American term. I said, well, that's a good point. But, this siloed approach, I do food security, and I do infectious disease, and I do, cottage industries, and it's not effective unless it can really be brought together. Same as
what
with
anthropology does.
And that's what anthropology does, and that's what anthropology reveals. Mm-hmm. Is how all of this fits together. And it's the same with short-term medical missions, right. Having them fit into a system where there's records, medical records, where there's adequate follow-up. And I think they're very similar kinds of challenges. Mm-hmm. I hate using the H word, holistic, but if we can have more holistic views of medicine, development, poverty, and how to respond to these problems, I think we'll be more effective. Mm-hmm. Thank you all.
Thank you so much. It's so nice to meet you.
Thank you. Thank you very much, Bob.
Thank you very much.
Thank you. Do I leave?
We hope you don't find that too distracting. No.
Thank you very much.
Please join us at the book signing and in the lobby, and thank you very much, and drive carefully.